We'll be focusing on, as you are aware, because of your selection and your interests, the fact that we are still experiencing the effects of dual pandemics, the systemic racism that has been longstanding and the COVID pandemic that has exacerbated the mental health crisis in our community. And when those two things in and of themselves are significant, but when they are happening simultaneously, the effects continue to plague us, and either those who are directly impacted or indirectly impacted because of a family or a friend or a loved one, it is something that is of significance to the entirety of the community. So please, again, keep eating. The presenters, we're going to give you a few more minutes to keep eating as we do these very brief introductory remarks. And after the final remarks in introduction, we'll invite the panelists up. But I want to now bring up the president of Thomas Hooker Brewing, Kurt Cameron, who is here with us, wants to share some words. And Kurt, thank you for this space. This is a new space for us to be gathering. It's my second or third time here, and I've enjoyed it. So congratulations to what you and your team are doing, Kurt. Appreciate it. Absolutely.
So hi, my name is Kurt Cameron. I'm the president of the Thomas Hooker Brewing Company. I was given two jobs tonight. The first is to welcome you here and welcome the Hartford Foundation for having their event here tonight. We really appreciate it. My second job is as the vice chairman of the Village for Families and Children. I've been involved with that organization for about 10 years. It's a fantastic organization. Some of you may be familiar with it. My relationship with the Village didn't start 10 years ago when I became a board member. It actually started many years before that. I was actually adopted from the Village. And so it's been an honor to serve an organization that gave me a fantastic start in life. For those of you who don't know the Village is a over 200-year-old private nonprofit. It was originally started as an orphanage, but fast forward to today, and it's an organization that runs over 40 diverse programs in our area. It serves approximately 18,000 individuals in the greater Hartford area on an annual basis. It has an incredible mental health component to it, from early childhood development programs right through to intensive residential treatment facilities. So it's an organization on any given day that's helping approximately 2,500 individuals in the greater Hartford area. And it's just a phenomenal organization. My heartfelt thanks go to the Hartford Foundation for not only for the financial support that they provide the Village, but also the vision that they help us with to really help us, work in this community and improve upon all the programs that we currently provide. So those are my comments for today. I want to thank you all for being here, and I believe I am supposed to introduce.
Well, hold on.
Okay.
I would like for you to share a little bit about this space. And
Okay.
What your vision is.
Okay, well, great. Well, so this space was actually developed in October of last year, and I thought, boy, was I smart. I'm hitting right the end of COVID, and we're just going to roll right in, and things are going to be wonderful. And then Omicron hits, in January, right? So timing not so great. But we got through that, and this is a space that we built. It's a historic building, so it has its challenges. But I think that the building itself has a lot of soul. And people ask me about Colt. Like, I don't know how many of you have been down to this area recently, but I always say that I classify Colt as that overnight success that took about 20 years to build, right? So right now, there's over 200 residential units in this complex. It's about 650,000 square feet. The Village actually has some space over here that they're running a number of programs out of. When in its heyday, it has about 1,400 employees working in this space. And it's just a phenomenal place with a lot of history. And we're proud to not only have this space, but a tap room and a cafe and a private event space over in the other building. So yes, if anybody needs private events, you know where to come, all right? So that's my plug, but thank you for allowing me to share that. And I think my next job is to introduce our moderator for the evening, and that is Terry Schmidt. Thank you, my pleasure.
Is there a mic?
Nope.
No, there's something here. If we go short, which may happen, I want you back and explaining more about Thomas Hooker, okay? Because I think there's a lot more to the story that we need to hear, to be perfectly honest with you, especially when it's run by somebody who has the very kinds of organizations that we are studying tonight. So you couldn't get any better than that. So thanks. So don't go away. Okay, I need to be loud. Where is the microphone that I'm using here? Is it this thing? Okay. Well, we can fix this. All right. I'm now tethered to this podium. I'm not going anywhere. Well, thank you all for coming out tonight on an ugly night, on a night that you managed to not be put off by the sign that said street closed. I don't know if that worried anybody besides me. We're thrilled to be together again, live, those of us that are here and that can be here. And this is the second educational evening that we're doing, leading up to our decision-making evening, which comes in October. So I'd like to introduce our presenters, and I haven't had a chance to speak with any of them yet, so I feel badly. If I mess up your names, please correct me, because we do want to get it right. But come up when I tell your name and sit here and figure out the microphones just like I've been figuring out mine. So Gianna Bracey. Where is she? Oh, there we go. Okay. Did I get that right? I looked at that. Gina. It's Gina. See, I didn't get it right. Well, off to a great start. Okay, so you have sheets on your tables, and if you look at those sheets, they have longer introductions to our presenters this evening, but we will say that Gina is the Associate Vice President of School and Community Initiatives at the Child Health and Development Institute of Connecticut. There are enough concepts in that last line that I read for us to go on for a long time, just explaining what all of those things are. But Gina, we're thrilled that you're here. Thank you very much. I'd also like to invite forward Dr. Lane Taylor. I think I probably got that one right. Lane, good. All right. Child psychologist. Thank you, Lane. Taking the middle. That's good. They're going to help you with the microphone, which is a good idea. So this is a person who Kurt could relate to. This is the child psychologist and medical director at The Village for families and children. So you two can have a great conversation, I suspect, at some point this evening. And finally, Marissa Giarnella Porco. Are you here? Thank you. Okay, thank you very much. Who is the president and the CEO of the Jordan Porco Foundation. And we will hear from each one of these presenters tonight. And we're probably going to do this a little bit like we did the last time we gathered together, in which you'll make a presentation, I may ask a question or two, and then we're going to go on to the next presentation. And then after everybody's done, then we'll open it up to questions from the floor for everybody. So throughout this evening, please put on your thinking caps, put on your philanthropy thinking caps, put on the kinds of questions we want to be asking these folks have to do with where's the most important places for us to be putting the money that we hope to be donating in the coming months. In October at our decision-making meeting. What are the kinds of things we might be looking for? So use that as a lens and think up some questions, because we've got three wonderful panelists who have things to present, and I think we even have one other person who may have something to say a little bit later on. Where did Betty Ann go? There you are. Okay, good. I do not want to lose sight of you. Okay, so let's start off with Gina, if you would tell us a little bit about all of those things that must be encapsulated in that long title that you've got.
Absolutely, yes. Thank you all for having me, first of all. It's a pleasure to be here, live and in person, as you've said. It's been a while since I've been at a live presentation, and especially without PowerPoint, so I feel a little out of sorts with like a notepad here, so bear with me. But yes, so at the Child Health and Development Institute, or CHDI, as we're known, our work is really around, our tagline is Bridge to Better. And we really see ourselves as catalysts for change and improvements for children's behavioral health and well-being. And so most of our work focuses around sort of three buckets: improving systems, we're talking particularly around child-serving systems, but behavioral health; improving policies, so better policies to support those services and structures that serve children; and better practices. So what we mean by that is often, it's not just about having a service available. The access is certainly important, but it's also about the quality and the outcomes of those particular services and practices, and what goes into monitoring those and making sure, again, as we talk about the dual pandemics, talking about equality and equity and what makes sense for all children to live their best lives. And so my background is, my training is in clinical community psychology, and but we, again, sort of do this more at a systems level at the 10,000 foot view.
Okay. Turn myself back on.
Sorry.
Yeah. Let's see if I can, I came back on again. Okay, good. So we've heard a little bit about systems, maybe not so much about policies and practices, but what we've heard about systems isn't good. It's a mess. It's a mess for everyone. It's especially a mess for people of color. So could you give me an idea or two of when you say we're involved in improving systems? Get specific, or give me an example or two of what that might be.
Sure, absolutely. Again, our work focuses most on, I don't know if this is picking me up, I'm talking the wrong direction here. Our work focuses mostly on the behavioral health system for children. We do only work with children's services. And not being direct service providers, we are really working at that systems approach. And what that means to us is, who are the players, who are the partners, who are the providers, how are the policymakers informed about what's happening? We talk about the trends. You have statistics on your tables about how bleak things look right now, the numbers in terms of intensity, and we certainly have seen that increase over the pandemic in terms of having more intense needs among children, and also just more long-standing needs that have come to the forefront. Kids that had needs before, or did not have needs before, are coming out as showing needs in terms of behavioral health, and kids that had needs before are showing that those symptoms are exacerbated. And so there's more anxiety, there's more depression, there's more symptoms of trauma being exposed, and there's more suicide rates have gone up as well. And so when we think about systems, it's not looking at those one-to-one individual children, but it's kind of stepping back a little bit and what's happening in the community, in the environment, in the nation that are perhaps impacting those. And systems really are just made up of people. They're also people, but they're people with some power in decision making and resources to set the stage in terms of the policy or the practice, and how those really kind of inform each other to make better improvements for children and youth.
So I'm going to push you even further, because I've got you here. And you're sitting next to a psychiatrist,
Yes.
Which is kind of my example. When I think of the systems, I think about people available to serve the needs of kids, psychiatrists, psychologists. You can't just create those tomorrow. You can't just say, oh, well, we need 50 more psychiatrists in the city of Hartford, so let's just go buy them. That doesn't work that way. It takes a long time to get to be a psychiatrist. It takes a long time to get to be a psychologist. So what can you give me a concrete example of a way that you're working to improve that particular part of the system? And I haven't even gotten to hospital beds yet, which would be my next question.
Yeah, absolutely. Yeah, absolutely. I'll give you an example from the school-based scenario, actually. So much of my work is in the school systems and working with school-based mental health. And we've developed a 5-tier approach, really, to address that and to kind of look at comprehensive school mental health as a systems-level intervention and as a systems-level perspective on how do you meet those needs of the kids that you're seeing. How do you get the workforce to address those needs from the beginning? You know, you can identify them, but if you don't have the service providers on the back end to support that, how do you make those connections? And so, you know, our 5-tiered approach starts with the 3-tiered public health pyramid that I'm sure you're probably all pretty familiar with. The first tier being prevention or health promotion. You know, what are those things that you do for all kids and everyone in the community? So that's building mental health awareness. It's building, you know, school climate if we're thinking about a school-based approach. Then you move up into the 2nd tier, which are more of those things that are targeted to some of those kids that have shown some needs or maybe at risk of experiencing needs based on their demographics or based on, you know, pre-existing conditions that might put them at risk. And so those sort of tier 2 things might be group level interventions. Again, if you don't have enough psychiatrists to meet with every single child individually, maybe you can do things in small groups for kids that have similar challenges that are happening. And then the top tier, the 3rd tier, is really those most targeted, most intensive needs for those kids that do need that one-on-one support or they have longer standing intensive needs that require that. And again, in the school system, oftentimes that's through partnerships. So we talked about the Village, you know, and they have excellent school-based programming and are an excellent partner for school systems as well, and meeting those needs and building some capacity sort of as a handoff where schools don't have that capacity internally to themselves. But when you really talk about the systems approach, it's those 2 additional tiers that we've added to our model. So kind of as the next foundational level at the bottom is a layer around workforce development and supporting a healthy workforce. And in schools right now, as well as all provider organizations, I feel like it's across the board, everybody's struggling, right? And the more that you're exposed to other people that are struggling and you're a helper by nature, you know, a lot of that gets a heavy burden to bear. And so really shoring up those supports for a healthy workforce, which means things like professional development and training. And it's not just one-shot trainings where here's your manual, now you know how to do it, but it's ongoing coaching, implementation support. You know, we tried it once, it didn't work, so now what do you do? You know, who do you have to help you with that, supporting you along the way when things might not go as planned? And then again, that final base of the pyramid that we would add in our 5-layer pyramid would be family, school, community partnerships. And I know that's something that's really important to this group. Again, it's not that the school has to do everything on their own or that any one provider meets all of any family or child's needs, but it's how do we do this together and how do we really build those partnerships so that we're leveraging the resources that are available and that you're really building a sustainable approach. And I think that's what's also really important about a systems level perspective. Again, that it's not the one-to-one support is extremely important, and so I don't want you to take my words differently, that I'm saying that's not important. It's absolutely important, but at the same time, it has to be built in within a structure that will help sustain it over time and to keep it moving in the right directions towards best practices.
Okay, thank you very much. Thank you especially for putting up with my grilling.
No, absolutely. Please ask more questions.
Well, we will. Don't worry. Trust me, we will. Lane, let's go on to you. You could just simply say, we produce people like Kurt, and here's what we do. And that would be pretty much done at that point if you'd said, but I suspect that it's a lot more complicated, a lot more difficult, and given the size of your organization, hard to manage in this phase. So tell us about the village and what you do there, and maybe with an eye towards what we might do to help the overall situation.
Yeah, absolutely. I've been the medical director at the Village for about 2 years now, so I'm relatively new to working there. And before that, I was actually an inpatient attending. So I worked at Yale University in the inpatient unit for little kids. So we were working with kids that were anywhere from 5 until about 12 years old, sometimes 13, that needed admission because they were unsafe to themselves or others. And actually, I'm bringing that up. It's not my current job. It was exhausting. I did it during the pandemic. I joined the village in the middle of the pandemic. I am grateful and love my current job. Let me just say that. But it helped to really shape the work that I see us do at the village. It helped to really shape how I view my role at the village. Insofar as I have a clinical lens, I view myself as a clinician, but also being able to see all the various programs that they have at the village and think about how I can see each of those kids I worked with on Winnie One is the name of the unit, and understanding every layer that impacted those kids, from their families to their schools to their communities, right? And that's what the village does. The village is able to hit every single aspect of what happens, how kids are involved, and not to mention also adult services, right? Because it came a point where we're serving all these kids, but the parents need support too. And so we started doing adult services as well. And so this broad-reaching role that we have played in the community has not just stuck within, it began in Hartford, right, in Hartford region, but it has expanded even further through the use of our in-home services, through expansion of programs, but also through telehealth services. So now we actually are embedded in pediatric practices as far out as Danbury. We're working on a Fairfield County contract in order to provide care to folks where they are. Right? They're going to their primary care offices. They're going to their schools. So we're in schools in Hartford and surrounding areas. So that's the village. And on top of that, we get to produce amazing people like Kurt. And we have recently been able to expand our foster care services, where we are going to soon become the largest provider for foster care in the state. Yeah. So it's very amazing, very cool, and fulfilling work that we get to do.
How big is the village? How many people does it serve?
I was like, we're between 500 and 600 employees.
Employees? Mm-hmm. Wow.
Are you talking about the number?
No, that's okay.
I have that number too.
And then how many people do you serve?
In Greater Hartford area, over 18,000, but it is far more than that if we start to think about our role in beyond clinical services.
So I have a friend who just wrote about a meeting that she's not sure she can attend of an organization that I'm involved with. And the reason that she's not sure she can attend is that she's going to be taking care of her 2 grandchildren all summer, 6-year-old and an 8-year-old, because their parents are in the midst of a meltdown. How do you even find out about a family in that situation? And what would you offer them as services?
Yeah. Actually, the pandemic proved that to be more difficult, to be frank. I think that there was a span of time in which families and kids fell under the radar because they weren't going to the places that they typically would go, and people would identify them to receive services, like their schools, like their primary care doctors. I mean, my son had his 3rd-year checkup via telehealth for pediatrician. He was like, is he sick? No, he's fine. Okay, then that's what it is. So, that was pandemic life, right? And so, so I think that was really halted, but that was also the cool thing about what was chosen to do during the pandemic at the village was, let's start to expand. Whereas most people were like, oh my God, are we going to survive this economically? We were like, okay, let's just invest and let's expand. Let's start to pay our staff more so that they'll stay with us so that we can grow and we can really meet the needs. Through telehealth, we were able to reach out to pediatric offices and primary care offices far, far, far away. For Connecticut, it's a small town. I'm from California, so Connecticut's tiny. But far, far, far away. And be able to say, hey, we can help you. We have a way to reach you, a way that can keep you healthy emotionally, but also physically, right? And that's a part of the other piece of what we started doing was we embedded clinicians in primary care practices because we needed to find the folks. We needed to come to them. We can't expect them to come to us. And I was really thinking about that question about systems and and there's a partnership like what we have on this panel, which is a very cool panel, that happens, and that's how this stuff worked, right? You guys kind of like, maybe knowingly, embodied what those partnerships looked like during the pandemic, and how we met people was through connecting. And then lastly, I think that when we think about systems, the existing systems are not set up to meet the needs of children of color or children in urban areas. They're just not. No judgment on it, it's how it was founded, right? It was founded on racist perspectives that narrowed the view so that you can't expect people to know to come to you, right? Because the systems aren't set up for them to know to come to you. So you got to take extra steps to go out to them. And sometimes that was even like at the village, like we have this surplus of money that we got. Okay, we're going to give out cards. We're giving out Visa cards to folks so that they could buy food, you know? And that was a way to pull them in. That was a way for us to reach more folks that otherwise would have nothing to do with us or know about us at all.
You got relationships with the black churches in Hartford and in the region? Because that would be an input.
Yeah, absolutely. So that's through our community-based, not necessarily like directly through our clinical programs, but through our community-based programs, which is another way, like as opposed to coming to places and saying, hey, why don't you use our services? It's like, hey, let's connect on a community level, and then we educate about everything that the village has to offer.
Okay, thank you very much. I really appreciate that. And it sounds like you're taking on a big, big, big job. But running away from Yale is a good idea. I'm all for that.
They say what? It's better to be from Yale than at Yale?
Yeah, absolutely. All right, Marisa, you come from a slightly different perspective. You're leading an organization that's a foundation that's trying to do something specific. Why don't you tell us about what your organization does and maybe even a little bit of the history?
So the Jordan Porco Foundation was founded 11 years ago. I lost my son. Can you guys hear? Where's it? Is this on? Hello? Okay, that's better. I'm going to hold it. How's that? We started the foundation 11 years ago. I lost my son to suicide. He was a college freshman. And just for background knowledge, I am a social worker by profession. I have worked in many different systems over the years. And we came up with a concept of the type of event my son would have attended. Because I was a social worker, because these conversations were not taboo in our home. And one of the things that I thought was, coming from community mental health and working for DCF and doing those things, I thought, you know what, if we're talking to young people, they need to hear the message from other young people as opposed to adults coming in and speaking to them. So we developed a program called Fresh Check Day. And this is a mental health fair with a little spin on suicide prevention that is peer-centered. It's run by the student groups on campus. And it has incentives for participation, therapy dogs, food, all the kinds of things that you're going to get in an upstream primary prevention type of program on a college campus, right? Kids love t-shirts, kids love food. We piloted our first Fresh Check Day at Eastern Connecticut State University in 2012, a year after my son died. We have now surpassed 900 Fresh Check Days across 45 states in over 300 colleges. So that's kind of our signature program. That's what we do at the Jordan Porco Foundation. We also, back in 2015, because of the demand and the out-of-state demand, we couldn't be boots on the ground anymore. So we had to make it turnkey, maintain our fidelity to the program, and be able to expand across the country. We also started developing our middle school and high school program. That's the For What's Next program. And then again, this is a primary psychological resilience program that really allows anyone working with middle school or high school students, regardless of setting, to really open up that mental health conversation, really to talk about coping skills. When is it time to reach in? When is it time to reach out? And especially bringing those conversations to students in the middle of their transitions from middle school to high school to college or workforce. So that is, we piloted that and worked on that for 4 years, and we launched it in 2019. That program's been written into some of the state and federal grants that we have here in Connecticut. We also adapted our Fresh Check Day program for high schools, middle schools, and businesses and communities, and we call that our check-in program. So it's kind of a mini Fresh Check Day program that anybody can package. And so if you're a church group, if you are a youth service bureau, if you are, anybody working in a community setting, or even high schools, like Newtown High School the student groups there ran the check-in for their high school students. So these are our primary programs. We are a small shop. Right now we're located in Wethersfield, Connecticut. There's only 8 of us in the office, 4 of us part-time. And one of the things that I think is really important is the work of partnerships in this space. We know that suicide was the second leading cause of death for people between the ages of 10 and 34 pre-pandemic, okay? It was a crisis then. It is only exacerbated by so many things that we all in this room know about. But one of the things, especially small operations like ours, we can only do it with partnerships with like-minded people. Because in my world and where I come from, and the way I look at this work, there should be no competition for this work. You know, we need to be working together for the benefit of our children. This is our workforce, this is our future, you know, and I think that we can never separate the educational needs of our students and the mental health needs of our students. It doesn't work.
So there's several things that come to mind as I think about this laudable work that you launched in the face of tragedy, and I know something about suicide. I'm wondering, though, about how you recruit the students that are going to be the peer leaders here. How do you identify and how do you train? Because you can't just take anybody and say, oh, go out and tell somebody that, you know, or spot somebody that might be suicidal and work with them. It's got to be much more rigorous than that. So how does that work?
So our programs are all about primary prevention. So what we're doing is we're working with usually the director, the student affairs person, the director of counseling at a college campus. That person then recruits the student groups that want to get involved. Okay. And so it can be the LGBT group, it can be the women's group on campus, because when you think about suicide and the different kind of, spokes to the wheel, it's never one thing. And it's about belonging, it's about connection, it's about knowing what the resources are on campus, right? This is your new village, right? You need to know who to go to. It could be depression or substance abuse screening at a college campus. It could be about learning healthy coping skills. You know, it's really about removing the stigma and kind of the discrimination about seeking help, but also getting that message in a fun way. So you're really talking about heavy topics in an environment that's opening up that conversation and making it a little bit less frightening. So the way we've worked it out is that it's all turnkey. They've got all the manuals, all the marketing, all the technical support that they possibly need to have a successful Fresh Check Day.
So the second thing that came to mind as I listened, we're trying to focus intentionally on issues of the racial disparity in mental health care, well, in healthcare in general, but the Hartford Foundation is focusing on the disparities in our region. You certainly have thought about this. Yeah. I'm sure of that. How do you address it with your unique niche?
So from our perspective, because I am a social worker by profession, everything we designed had the cultural adaptability embedded into it. So if you're a historical Black college, or if you are a community college, that usually is serving underserved populations, this program is adaptable to your setting. Same with the For What's Next program. If you're a middle school after-school program and you don't have a lot of resources and you don't have a lot of credentialed people on your staff, you should be able to have that conversation about mental health and open up that trusted adult kind of conversation with the students that you're working with. And in my experience, And I think I had this conversation with somebody earlier, is that right now what I'm trying to do is find grant funding sources to help support some of these smaller grassroots organizations that are on the ground working with underserved populations, because even a small amount of money could be very difficult for somebody who's got a small budget. What I'm also finding is a lot of the folks that I've been talking to, they are seeing all the mental health crises that are coming through your door and through the hospital systems, but they don't have the policies in place. They don't have the protocols. Their folks are not trained. So you end up doing a lot of consultation about how to start with baby steps so that you're not intimidated when you're in the middle of a full-blown crisis happening. And it doesn't matter whether or not you're a college success program and you think you got your kids all dialed in, or whether or not you're just meeting a student for the first time. These folks are dealing with these crises, and they don't always know who to go to, and they don't even know how to react. So we try to bring it in gently, and just, again, starting that conversation. And also, I think because of the lack of staffing, what we find is people are asking us to come in and do the training, but we feel from the development of these programs that it's the folks that are working with the students on a regular basis that are the trusted adults that these students need to have these conversations with, not some stranger coming in and teaching them. It needs to be the people in their own community that know the parents. So that's how we address this issue.
Okay. So I've got one big question for all three of you in just a second. But before that, I want to make sure that everybody here has got questions ready, right? Okay. Why did I know you'd have your hand up?
I always have questions.
And we'll do that in just one. Yeah. Oh, actually, you know what? Can you wait just for a second? Because you got one more. And I won't forget you. I don't forget you on the Zoom meetings either. So Betty, Ann, you've got someone who wanted to say something, and then I'm going to hit my big question with these folks.
I was going to ask another question of the panelists, so I don't want to mess up where you're going with that. But I thank all of you for your presentations, and I know we're jumping around a little bit, but there's so much more we want to learn. But Dr. Taylor, one of the things I think we would be interested in hearing about, we've talked some about systemic change, we talk about service providing, we talked about prevention, but could you speak a little bit to the grant that the Village has received from the Hartford Foundation that is unique, partly because it's big and it's multi-year, but it also has a very specific piece for behavioral health and mental health. And I'd like to hear about what kinds of services are those and where are they provided?
So the Hartford Foundation has been incredibly generous to the Village and has awarded us a very large grant, and it is a grant that has allowed us to actually support the broader range of programs that we have. So that we have like individual smaller programs that need support, additional support, more than what the smaller grants can offer. I mean, I'm probably speaking to the choir about this, but the reality is, like, a grant gets put out, sometimes it'll be like, hey, you're gonna cover all of this, but we'll pay for that much, And so what has happened is that the Hartford Foundation grant has allowed for us to really expand and really develop so many programs. We're able to look into doing things that are more addressing social determinants of health. So we're starting to think a little bit about the role of housing in mental health. We're starting to think about how to really develop and build our foster care system. So there's some really specific programs that we're able to allow blossom more as a result of the foundation support.
Got a follow-up to that?
Sure, thank you.
Okay, that's good. Thank you for sharing that. Betty Ann, you had someone else who wanted to say something, I think. This would be a good time.
Okay, we'll let Ira, oh yes, okay, thank you. Alieska, I'm going to introduce you. So Alieska Tilley works with the Jordan Porco Foundation, and she could have been on stage tonight, but we were trying to organize it. Come on up, Alieska. She was in traffic, I know. But we invited her here tonight, and she's willing to, here, you may want to chair up there too, so you're not standing up there all alone. She's willing to share her story with us, and so I know you all will be interested in hearing that. I'll hand you this microphone.
Oh, okay.
Thank you for coming.
So a little bit about my own mental health journey and kind of why I came into this field. I didn't realize it at the time, but I started struggling actually with my mental health in 8th grade. I started having really bad self-esteem issues, not so much of an interest in social activities. I felt very isolated, and I came to realize my senior year of high school that I was struggling with depression at the time. But I didn't quite know what was happening. I didn't really know the signs. It wasn't really discussed in health class, so I wasn't aware of what was happening. But I started struggling with that in 8th grade. And then sophomore year of high school, I started getting panic attacks. And I had no idea what a panic attack was. I thought that there was something physically wrong with me. I really didn't understand what was happening. And so for the few years before, since 8th grade, I was feeling very down, feeling really bad about myself, not knowing what was happening, and now all of a sudden I'm getting these bursts of not being able to breathe, panicking, and feeling like the world was crumbling around me. And I really didn't understand what was going on. It was not talked about. It was really not ever a conversation in school or amongst peers of what was happening. And I found out actually online through social media what was happening. A couple of people had posted, "Oh, have you ever heard of what a panic attack is? These are the symptoms." And to be at that age and have social media as your form of finding out your mental health issues is kind of a scary thought. Reflecting back at it now, being 23, I'm like, that's kind of scary that that's where I found that information, because there was also a lot of dark information. That's where I learned how to self-harm, and a lot of very, very negative things were put in my head through that platform. So it was kind of a pull for me of being like, oh, I find really negative information on here and really bad things that I know I shouldn't know, but at the same time, this feels like the only resource for me. And I knew that I needed to get help my junior year of high school. I knew that having panic attacks now was not normal, and that I was struggling with depression and had been for a number of years. And I didn't know what a school social worker was. I didn't even know that we had one at the time. I went to Danbury High School, and I believe that we had maybe 2 or 3 social workers for 3,000 kids. Yeah. So it was just not something that was talked about, or if it was, I had 1 or 2 friends who went to the social worker. It was kind of like, well, I've been seeing the social worker since 7th grade and I kind of have to. Something had happened in their life where they were put into therapy. And so I didn't really think that it was appropriate for me to go to that person for help. So I really struggled for a long time to find what resources were going to help me and what resources were available. It really wasn't until senior year of high school where I went to a private therapist because I was able to drive, and I had a job so I could pay for it. But I struggled since 8th grade because I didn't know what resources were available. And so I chose to get a degree in psychology, and now I'm getting my master's in social work because it honestly was ridiculous that I couldn't get help because I didn't know any community centers around me. There was no conversations about mental health. There was very little happening in health class where we would briefly talk about depression, eating disorders, self-harm, and then move along. And it wasn't, hey, these are things that happen. Here are some resources in case you know someone who's struggling. It's more like, oh, well, certain people struggle with this, but we're not really going to talk about it. We're just kind of move on. So I just really wanted to get into this career to make sure that there's programs being out there. I want to go into policy now and really create change. And so through my own experience, I just know how alone it feels. And I think a lot of people, when they hear, oh, it feels alone, it's this peer or social aspect. And really, it wasn't that. I knew so many other people who were struggling with the things that I was going through. It's more feeling alone and not knowing where to get help and not knowing what resources are available and feeling like adults are not talking about it, or if maybe they are talking about it, it's very stigmatizing and not in an open, positive manner. And seeing so many people supporting the mental health industry now is really very beautiful to me, because I know that there's so many young people out there who are hearing these conversations happening and seeing people act together to bring resources to the table. But yeah, there's a lot of loneliness in the sense of not knowing where to go. And I think it's very important that we're having these conversations right now, and providing kids and adults with the resources that they need to get help.
Okay, so thank you so much for sharing your story. That certainly takes courage, and I also suspect, though I'm just sitting here looking at the rest of the panel and thinking that when you get done with that master's degree, I can see 3 people who might want to hire you right away. So useful evening for you and for us as well. So thank you very much. All right, so I've got one question, then Iris, I'll turn to you after that. So here's my one question. It's to all 3 of you. You each have to answer it. And I'm positing something here, but I don't think I'm going very far out on a limb. I suspect each one of you, at one point or another, maybe many times in the week of facing your work, has said to yourself or to colleagues, geez, I wish somebody would do something about blank. Okay? What's that blank? What's that blank? And we want to know, because that may be what we want to try to address with our grant. So it's really important to us. So think about that. I do this all the time. I wish somebody had done something about, fill that in for me. Who can do it? I won't force you to go first. So anybody can do it? I will force all of you to answer it, however. Go ahead.
I'll go first, just because it's the reality of small nonprofits as well as big organizations.
We can't hear you.
I'm sorry. Here we go. It's dropping down. I think I'd just be. It's the situation of just having financial support to do the work, and also having something not be so difficult to connect and network with people and making things happen. I think the bureaucracy. Why do things have to be so difficult? To try to do some good.
I wish someone would make it easier.
Yeah.
Okay? All right?
I can go down the line.
Yeah, go ahead.
Literally within the last week, I have 2 different families. So I'm medical director, administrative work, but I also do a lot of clinical work, and my clinical work is primarily focused on a residential. So outside of the hospital level of care, that's the highest level of care that's offered in the state of Connecticut. And in the last week, I have had 2 families experience great loss. One mom lost her job because she needed to show up so much for her child for therapy services, for crises, for school meetings, to the point where her boss literally told her, it looks like things are too complicated with your son, and so I won't be having you work here any longer. And she has 2 other children. Her child who struggles the most is living with us, and she can't afford the gas to come out and do the therapy. She's trying to figure out how to feed her kids, how to pay the electricity and the cable bill in order to do remote therapy, right? Do the telehealth work. There are programs that exist that address this, but it is happening more and more. My second parent, she doesn't have a home. She lost her home. There is an eviction moratorium that ended, and rent prices are exorbitant these days, and wages aren't matching, right? And so it's hitting mostly our urban centers quicker and harder. What's happening with inflation, with gas prices, with rent prices, with the evictions, to the point where, and we can think about, that's poverty, that's financial. Those are social determinants of health. That's our lingo, right? Social determinants of health. And what does that mean? That means that your environment, what you have for yourself, impacts how healthy you can be. And so that's not just physical well-being, but that's emotional, right? So if this mom can't afford to buy her children nutritional food, right? She's not allowing them to be able to have healthy, fueled bodies, which lead to issues with mood, which lead to concentration issues. if she's not able to show up for her son who needs her to be there, but she can't afford the gas to get there, right? I mean, $100 to fill up your tank these days, right? And how can she be what her son needs her to be? So that level of economic strain puts strain and stress on families. And what manifests, what rolls down that line, that stress is parents' own anxiety, parents' own depression, conflict within the home, and on, I'd like to say extreme, but let's just be real, it's not that extreme levels, higher levels of conflict in the home, neglect and trauma, right? And so what we're seeing right now, for just being real, as privileged individuals in this room, right? Because we're here, we have this level of privilege, we're annoyed by what's happening, right? But we're not facing the potential of losing our home tomorrow. That's what's happening to our children and families who are already struggling with their mental health issues. So there is actually an answer for this. It's called care coordination. It's not the full answer, right? But care coordination or case management, this is a way to be able to have someone who goes into the home, who works with the families, develops a relationship with the family to understand what are their needs, down to how do I figure out how to set up this appointment, or how do I get a phone, what we used to call Obama phones, how do I get the state-funded phones, how do I navigate all these resources, how do I know where to look, right? And so there is an answer to it. We need the resources that they can refer them to. But at least they walk through and get to know the families and get to know their needs. That, I think, is a real need for investment.
I'm not sure I can summarize that one. I think I'm just going to have to let it be. That was very detailed and wonderful. Thank you. Okay.
Well,
Gina.
to sum up, I think my comments are really inspired by Alieska. Did I pronounce that right?
Yeah.
Alieska. Beautiful name.
Thank you.
I want all kids to have the opportunity that she had to come out on the other side with positive outcomes. And that happens through a comprehensive, coordinated, statewide approach to school mental health and comprehensive school mental health framework. All of the things that you mentioned, only having 2 social workers for a student body of 2,000 or 3,000 students. There is a policy about that. We have adopted a policy. There should be 2 for every 250 students, 2 social workers. There should be 3 or 2. There's a number for this. So one, for us, how many psychologists for every 300 students, right? And those ratios are not being met. So having the opportunity to actually serve the students who are showing the warning signs or experiencing difficulty is tremendous. And also not, you mentioned not being aware, not understanding what was happening to you, having these feelings and symptoms, but not having words for it or not knowing where to turn. Again, that's mental health promotion and mental health awareness at the earliest levels. Those are tier 1 universal things that should be provided to all students in schools. And part of what prevents that is the fear that if we uncover it all, if we screen everybody for suicide in our school, we're going to find this overwhelming need that we can't meet. We have 2 social workers. How do we meet? Now we've uncovered all of this, and if we ask about it, it's going to come out. So let's just not ask. And then, only those students who have the most, intensive needs that come to the forefront, either they have extreme behavioral outbursts in the school, or they have behavioral challenges or discipline issues, or otherwise in terms of self-harm or suicide attempts or attempt to hurt someone else, then those are the kids that we respond to. And that's when we get involved, when we respond to the crisis. And so we're constantly putting out crisis after crisis after crisis. And during the pandemic, everybody's in crisis, and the crisis just keeps piling up. So you never can get ahead of that without, again, a comprehensive approach to really thinking about what training and support for the staff is needed. Maybe you had one connected adult to you that might have known what to do, or maybe you would have talked to that person, but would they have known where to go? What would they do with that information? Is there a support system built in? Is there a clear decision-making process from that step to the next step to the next step? Even if you have the fresh check day, that's fantastic. And we've done some partnerships with your foundation, and it's wonderful support. And I just love seeing it expand beyond Connecticut and nationally. It's such a fantastic model. But again, in isolation, it is, it's the one day, and how do you build off of that? It's so, you don't want to lose that momentum and lose what you've uncovered in that one day. Or have kids say, why bother? Like today they care about, but tomorrow there's nothing they can do about it. So again, having a really strong decision-making process that cuts across all of those, not just the kids that are showing the most severe needs and the crisis situation in the moment, but all of the kids before they get to that point. What do we do preventatively? How are we supporting the staff? How are we connecting to those community-based providers that have services available in the community that the school doesn't have to do it all? How do we know, okay, here we've taken as far as we can, now let's connect with our local provider and make that warm handoff so that the family is getting everything they need, comprehensively. It's not just, okay, we're gonna address the mental health challenge right here. Sorry about all those other factors that the family is dealing with. But again, that family school community partnership and making sure that there's a common linkage. And one final piece that kind of goes along with that is the data support, right? So how are we monitoring, tracking, and knowing what works and what are the positive outcomes and what works for whom? So again, you can have, maybe Danbury didn't have that particular model at the time when Alyeska was there. Maybe another district does. How can we make sure that all students, particularly in Connecticut, have equal access to that structure and that process, and that they all have the benefit of living to their full potential and having their best outcomes?
You didn't answer my question
I did not
easily.
answer your question.
No, easily. You
Okay.
answered it. I mean, I wish someone would make this monstrously complicated,
Yes.
interrelated problem
Yes.
simple,
Yep.
but it's not.
Yep.
It's not. Okay, thank you all. Don't go away. We're not done. Yeah, Betty Ann, could you grab the microphone back? And Iris gets it first. And we're making sure, because we can probably hear you up here, but everybody else can hear you unless you use the microphone.
I'm a social worker from the bad old days.
Yep, is it turned on? I'm not sure it's turned on.
Is it on? I was there for 7,000 children in the Bronx. But what I'd like to know from you folks who have programs that sound wonderful, and I'm sure they are, how long does it take from the time a youngster is identified as needing help until they actually get it? Because I've heard many, many different kinds of time, and 3 months and 6 months and 2 years on a waiting list is dangerous. The other issue that comes to my mind is a young lady who spoke at our last meeting, who was a member of a minority group in a very upscale Connecticut town, who did not have many allies among students, and found what people really thought about her on social media. And she was available as a support to lots of kids who said, well, what are we going to do? And who gives these kids support in identifying youngsters who really do need help, but don't have a place to turn and don't have a parent they feel they can speak with? So it's how long does it take to get help once they've been identified, and who's there for the auxiliary help in the meantime? Thank you.
Okay, who wants to take a crack at that? I'm looking at Lane.
I know. Just concretely, I think it depends on the level of care, which determines how long you have to wait. So if you're looking at just outpatient services, you can walk into the village doors and get an intake and get set up with therapy. For psychiatry services at this point, for child psychiatry, we have a 4-week wait to get into a psychiatrist, but you're seeing a therapist weekly up until that point, so there is some bridging. If you're talking about the highest level of care, residential, subacute, which is a 4 to 6 month program, we are full. And in a way that we haven't been full since I've been there. With both kids that range from right now 7 years old to 13. And our list is growing. And we're trying our best to get them in as quickly as possible, but the reality is, workforce shortage issues, and I know we think about, oh, how many psychiatrists we need, how many psychologists or social workers we need. We need the folks who are like there with the kids. It's a hard job, right? These are individuals that are straight out of college that don't have any particular clinical training, but they're helping to take care of these kids that are at the highest level of need. And it's hard. It's very hard for them to stay in the job. And, you know, quiet as it's kept, they can go do a job at Amazon for the same amount of money, right? So, that actually winds up being a limitation for our growth, right? And we're actually looking to try to grow so we can meet more of that need. But that's why we try to work on it downstream to prevent those kids to have to get there. But we're in the wake of this pandemic where everything has gotten so much more intense. So right now we're looking at the end of, we're looking at a wait to the end of July. We have one kid that we can get at the end of June, in next week, and then otherwise the end of July for those higher level kids. And then oftentimes those kids are waiting in emergency departments, which again, downstream, right? Kids stuck in the emergency departments, not in emergency departments, in hospitals, then lead to more kids stuck in the emergency departments because there's no beds, then lead to kids who are in the community that are just struggling and struggling. You don't find out until a crisis. So unfortunately, it is hard, but I think, and I'll lean on my colleagues to speak more to this, but I think that's where you look at sort of allied systems, non-clinical support systems to be able to do some scaffolding and provide some support that doesn't necessarily require you to have, you know, an LCSW, but that instead, you know, you're a mentor, you're some other positive adult in that child's life.
While we're on this topic, Terry, if I could interject again, we have in our presence tonight a woman named Melissa Deasy, who works for the Institute of Living, who is another care provider and does a lot of residential services. And Melissa was scheduled to present at our April meeting, but she was sick, so she was not able to present. But she's here tonight. So if I could, Melissa, just give you the mic for 1 second, and you could talk a little bit about the Institute of Living and what you see in terms of Iris's question around wait times and availability of services.
Thank you. And I just want to applaud the panel. We've worked closely with each of you, and collaboration is the key. We're all in it. And to answer your question, the million-dollar question is self-care for the staff doing the work. Recruitment's one thing, but retention is hard during this time. And so in terms of wait times for our child adolescent services, I have to agree, it depends on level of care. For about 13 years, I oversaw all of our child adolescent outpatient programs. And to get into an outpatient clinic, very similar, we can get our youth right in the door. But for our day programs, which is more 5 days a week, 4 hours a day of group therapy, it could be anywhere between a week to 2 weeks. I was on the conversation with a father the other day who was saying it took a month to get into your program, and now we're going on vacation. And we were talking about whether they should stay in the program or not. I mean, right? Vacations are important. Family time's important, and so is treatment. So it's a conversation with our families. It's really, as much as we can, including them as part of the treatment. We're not going to be able to treat everyone, and not everyone needs this level of care. But as you talked about, if we could do that early intervention, we do this wonderful program called Youth Mental Health First Aid, where we go out to the schools, we teach the schools, we teach the physics teacher to ask the questions, are you suicidal? Do you want to kill yourself? Because those are the youth, those are the adults that they are trusted with, right? Not everyone sees a counselor. So it's really early intervention, the education, the teaching, and the collaboration of, you know, knowing who to partner with, and also including our families. And they are so strapped as well. And so it's really coming from a strengths perspective. I believe very strongly our families are doing the best they possibly can. And so how do we support them in that? Instead of beating them down, they're not doing enough. It's how do we build them up? How do we build them up? So again, great work.
Okay, other questions that we might have as we're sitting around here? Yeah, Bob. Bob, get Bob.
Well, let's start over here since we're here, and then I'll go over to Bob.
Bob, I'm not in charge.
We're saving her some steps, that's all. So this is such a complex issue, and there's so many different invested parties, children, the families, siblings, grandparents, et cetera. I think about my kids and who is probably next in line to that direct group and who they trusted as adults, and it's the teachers. And when you look at all the stats you're seeing of who is really impacted and hurting as a result of just the anxiety of the pandemic and dealing with children that are all really, really stressed out. And these are caregivers, as you said. These are, I would love to hear more about programs to help teachers, since they're in line there with the kids, they see the behavior, they know the families to some extent, about them knowing the resources that they can connect families and children to. Are there any programs around that you can describe?
For you. Yeah, so I can speak to that a little bit. Again, we're not direct service providers, but that's the role. Our role is sort of an intermediary and connector between those service providers and the resources and sort of what's out there. So one of the initiatives that we run is called Project Aware, advancing wellness and resilience in education. Again, I'm a broken record, but it takes on that comprehensive, multi-tiered, approach. And what's really important is that there are multiple different programs or different curricula that address that. You have mental health first aid. You have, now the state has rolled out DESA as a screening, as a strengths-based screening for social emotional learning and supports for students. And there's a staff component of that. There's restorative practices as a way to build sort of community and broad sort of school climate supports, that starts with the staff and making sure the staff have a good foundation and support and are able to articulate their thoughts and feelings and feel like they are part of a team. So that there's not competition, or, oh, I'm struggling in my classroom today, I really need you to step in so I can take a 5-minute break. And it's like, no, hold on, that's not my problem, I've got my own kids. Building a structure that is supportive of that first before introducing those things to the students and helping the students then understand and process their emotions. Ruler is another kind of example of that. One's very specific program out of Yale that's, helps kind of respond and kind of recognize, understand, identify emotions, and then how do you appropriately respond to those. And again, those things are both start with the staff. The way these curricula are rolled out, they start with the staff, and then once the staff are comfortable with it and you have an opportunity to process amongst them, then you introduce it to the students, and so that they're prepared and have had experience with the process themselves. And again, you've built that support system. I think what's really important is that a lot of times you hear, since the pandemic, you've heard so much about self-care, right? Self-care, it's so important for self-care. But you can't have self-care a lot of times without permission. Mm-hmm. Within a school district, you can't just leave your classroom and say, I need a breather, I'm gonna walk out for 10 minutes. Kids, do your own thing. You really need to build in that process. What is the leadership and the administration doing to support that and saying it's okay? And not only it's okay, it's expected. Here's how you should or can engage in that and making it acceptable part of the thing. So you're not feeling guilty or you're not making up for it or punished for it in another way by taking that self-care. And so I think changing the language around it, so sometimes it's not necessarily a specific curriculum about this is the right way to do it, but it's setting it up in a structure so that you roll it out with the staff first so they're comfortable with it, you then bring in the students, and that you have those policy and systems level supports that then impact that and make it not only, again, okay, but required and sort of acceptable that you actually engage in it in that way. And it's so important. He talks to you about some of the flexibility in you were talking about clinical supports, I think, in terms of certification and those sorts of things. And I think thinking about that in the school system is really important as well, because we have to shore up the workforce in the school system, and even bringing in more peer support partners, bringing in, some people, maybe you're a certified math educator, but you're really good at connecting with students, and you are that one, caring adult for so many, is finding a way to make it acceptable to spend some time in advisory or whatever it is, so that you are using people's strengths, not necessarily their training and certification, until you can kind of get there and kind of meet all of the needs that you're seeing, because it is so critical and the stakes are so high that you can't afford not to.
I'd like to just add to that for a second. Can you guys hear me? Okay. I think that not only in school systems and changing the culture of caring, right, but I think in businesses, you think about the woman who lost her job because she's struggling with a child. Right now, in terms of employment and hiring, you need to really adapt to what the needs of the employees are. So, and this is part of it, because the mental health of the parents, the teachers, right, the caregivers, all the folks that are out there on the front line, all that matters in terms of having successful systems down the road to enhance the welfare of our kids. And so I think as business leaders, we need to really kind of model that. We need to model that in our home, the self-care, the conversations, but we also need to have practices in our businesses that offer more grace than I think we're used to.
Thanks. Bob?
Terry, thank you very much for this topic that we've chosen this year. I think the Catalyst deserves credit for bringing this panel together. I think this is an issue that's involved very much with our family. We have a personal experience with somebody who's been depressed, was on suicide, and even a suicide alert. Fortunately, they've worked through it, so we can relate to a lot of what you're saying and appreciate what you're doing to helping others. That brings me to my question. Terry asked the question of what. I'd like to ask the question of which group. We heard a very interesting story about somebody starting with depression in middle school. Is that the group that the Catalyst should put our money to, or should it put it with high school, or which group? So I guess I'm asking the panel, which?
Well, I have that is a tough one, all of them. Is that an option, all of them? I have one example that may speak to that a bit. One of the programs that we did actually, co-develop at our organization at CHGI together with our state partners back in 2008 was the Connecticut School-Based Diversion Initiative. And that initiative is specifically to prevent arrest and in-school suspension and out-of-school suspension among students with behavioral health needs in our schools. And so that program has been very successfully running for the past 13 years all across the state and actually in other states as well. But what we noticed relatively early on is that we focused on middle schools and high schools, and because that's where the numbers of arrests are. And so you working with the older students, the teenagers, and they're having those, again, most kind of intensive needs displayed in terms of actually acting out, or to the point of where law enforcement is involved. And what we quickly learned is we need to be in preschools. We need to be in elementary schools for sure, but we also need to be in preschools, not to prevent arrests directly, in that age group, but because the foundation of building those social emotional learning supports and building the emotional capacity to handle disappointment, to deal with emotions, to process frustration, all of those things happen much earlier on. And so without having that early intervention and that earlier framework, catching them at the very end, tail end, or the tail end of the developmental spectrum in terms of schools, but right as they're going into that school to prison pipeline is not early enough. And so we've heard, catching them upstream and how important that is, and it is critical. And so that's one, I guess as a part two to the previous question, that's another thing that I would definitely, fund and support, is that, we've developed that model and what that would look like at the earlier grades, but again, needing to pilot that and actually put it into practice and show that it is, and not, again, it's not in isolation, it's really that whole continuum. And so we work at a district level, so not just kind of one isolated school at a time, but you work with those feeder schools, because if you don't have your training and teaching and supporting the youth to kind of, learn different skills and approach things differently, but then you put them in a system that is equally as punitive as what they came from, they're still going to have that problematic kind of trajectory moving forward. And so working with a whole district approach, again, going all the way back to preschool and earliest development, we're finding is the most effective approach.
Okay, yeah. Oh, George? We get George first? Okay, then we
This is, you know, when you say all of the above, okay, it sounds like the shortage of people is enormous, and we can't solve it all here, but what is the level of shortage of people that we're talking about? It sounds like it's probably, for the state, it's thousands and thousands and thousands of people.
Yes.
Is that?
I don't have an exact number,
No.
but that sounds accurate to me. And you know, given the number of retirements that are happening in just a week in the state systems as well, I mean, I don't think we even have a real idea of the magnitude of how that's going to impact everything as well. So, yeah, I don't have a number. Maybe one of you have a number. Yes. It's enormous. And I think that goes back to the point of we're not going to solve that. And I mean, probably not even in this room, you know, with years and years, or you can't continue to throw money at it necessarily and solve it as a problem. There really is a pipeline problem, and starting with education system, right? So, I mean, higher education. How are we training people? How long does it take to get people in those positions certified? How are we incentivizing them once they get there to make sure that we're retaining them? You know, how are we recruiting a diverse population of providers that feel comfortable and, you know, are well suited to serve the populations that they're placed with? And then, you know, how do we, there's just so many questions, no answers, but how do we make sure that all of that happens? And I think one of the other pieces that came out tonight is about silos, right? So, you know, just continuing to say, even if you are a provider agency, say, hey, we did identify this kid, you're on our wait list, and when we get a spot, we'll serve you. You know, stepping back and taking a more family-driven approach and saying, what we need is to attend to the young person's needs. And so maybe I don't have a slot for you right now, but can I call you and do a warm handoff and say, hey, Lane has space. Why don't you go over there, and, you know, you'll get the same quality care that you would have gotten with me. And so not being able to share and kind of leverage resources that are available, because there are some service categories that have openings, and there are some that are underserved, you know. And so it's figuring out where those needs are and then reallocating those resources, and not holding on to those silos, or keeping that structure in place just because it's been written that it should be that way. But what makes the most sense into actually serving those needs, I think it just takes some creativity and some innovation to kind of think outside the box with that. I think one thing too, just another thought that came around, somebody mentioned telehealth. And that's another innovation that was allowed or expanded during the pandemic, and continuing to, you know, support policies that allow that even further and continue to expand that and to support that. There are some considerations about having the multi-state certification, so where you don't only have to be Connecticut state certified, you can be certified in Massachusetts, or, you know, and having reciprocity to be able to serve, you know, if you live here or you want, or maybe you live there, but you have an availability to serve people here, to open that up and make that accessible as well. Because again, at the end of the day, it's really about protecting and serving our youngest and most vulnerable kids and families.
Thank you. I want to thank you all for educating us. Your comments are wonderful. Dr. Bracey, in particular, your thoughts about the crisis and moving our focus more towards intervention or addressing beforehand. I'm not and don't have any background in mental health, so bear with me if this is a very naive question, but I have to ask, is there such a thing as prevention? You know, is there a way to create psychological resilience? And is there a way to do that builds the workforce in a different way, like having home visitors go into the home in a paraprofessional model to train families at a very early age about social emotional health, or having pediatricians who have an integrated model help families understand what it takes to build a healthy, emotional citizen today. Or for parents, I have 2 children that I thank the Lord that they went through school when social media was not what it is today. How do parents navigate social media to the benefit of their children's mental health? So, I don't know if this is, something that's even possible.
Yeah, no, you're absolutely on the right track. I mean, all of those are possibilities and things that are being done, and certainly things where there could be more support, for those types of interventions or prevention or early intervention and prevention activities. Again, when you talk about the school system, I mean, having a curriculum, building mental health into and social emotional learning into the school-wide curriculum, that everybody gets it, so that there is awareness. Oh, when this happens, this is what it means. Here's here's what you do about that. Here's a process for once that awareness and recognition is acknowledged, what do we do about that? And normalizing it in some way. I think that's one of the positives of the pandemic, if we want to call it a positive, but just the ability to normalize it. Everybody went through it. All of us went through it. Some of us, in a more, more than others in certain ways, but we can all name someone that we lost through the pandemic. We can all list a way that our lives were changed in the pandemic. Again, some of them might have been minor inconveniences or annoyances, but we all can relate to, just the enormity of how things change and the impact that it had on all of us. And so that is sort of a normalizing event in some ways, and it opens the door to say, hey, we all went through this, here's how it affected me, here's why I'm feeling about it. Or most of the time I was okay, but there was one day that was really hard. And just being able to, again, recognize that, bring it into the setting so that, there's a way and a space for it to be able to process that, and then finding those creative outlets, building on peer support providers, building on, others that have advocates, for example, who've maybe been through that process themselves and have navigated the system and have figured out how to, how to access things and can help support that or bridge the gap until you get into that next step that you're waiting on. All of those are really creative and certainly valid opportunities to support. Sharon? Andrew?
Okay, yeah.
Hi, thank you very much for a great presentation so far. These have been great 2 meetings, our first meeting and our second meeting. I'm going to try to pronounce it Alieska. Mm-hmm. Okay, got it. Thank you for writing it down, Betty, and so I can know that. You talked about social media, how that's where you got your first entrance to learn, because it's on the internet, because it's true, right? It's on the internet. But we also know that social media for your generation, I've got a 24-year-old daughter, a 26-year-old daughter, is a place of communication. It's a place where they do get information, and we have to acknowledge that that is actually a decent source and opportunity where we're seeing what are the solutions, and we can't solve everything in one solution, but we also need to communicate. We also need to inform and educate. And is there a way, and probably obviously there is in some ways, but how can we make social media our partner? And how can we make them part of us and put it in a safe area, in an informative area, to at least help them, even in a way self-identify, to each go that next step? Because that's really what it is, the next step. I know you're aching to talk. You got something to say. So please talk to us about it.
Yeah, honestly, one of the best things I ever learned from my mental health was through the internet. It was the only thing that ever stopped me from having panic attacks, and it's a grounding exercise, a coping mechanism. I'm a huge fan of coping mechanisms. I think it's a great prevention technique, and I think that through social media, it's a great way to spread them. It's the 5, 4, 3, 2, 1 technique for anybody who knows it or may have heard of it, and that's something I literally learned from someone posting and saying, hey, I struggle with panic attacks. This is what I use to help me. It wasn't a professional of any sort. It was just a person saying, this is what I experience and this is what I do for it, and it's the only thing that's ever helped me. And when I worked at the psychiatric unit of a hospital for New Vaughn's Health, I told all of my patients it's an incredible thing. And I think when we're branching into utilizing social media, it's a super powerful tool, and I think that we should utilize it because that's what the generation is using to communicate, and that's really what what's being fed to them. It's really what's being fed to them. But we have to first address the negatives of social media, I think, before we really hone in that tool. And that would start at the policy level of making sure that we're having regulations on these websites of what actual information is being published, that is real information, that is coming from a real source, that is, not putting negative thoughts, because again, I did learn a lot of negative things from the internet as well. I have to say that most of them are positive, but I know someone mentioned having a kid in this generation, and I am very thankful that social media really started for me high school, like early high school. I didn't have access to it in middle school, didn't have access to it in elementary school, and there are children in 3rd grade on social media. And so I think that we first need to kind of address a way to ensure that proper information is getting out first and foremost. And then utilizing social media presence, whether that's through professional clinicians getting out this information. I know a big thing that's happening on social media platforms now is even if you search the word suicide, self-harm, any of those kind of trigger words, a resource button will pop up that says, do you need help, and direct you to resources. I think utilizing that type of systematic approach can be really good, but we need to then tailor that to your specific location. So, the national suicide prevention line is now having the 988, and making sure that here's Connecticut resources specific to your local area, or oh, you live in Danbury, here's a nonprofit or a behavioral clinician near you. And so I think that we could really, really utilize that tool if we make it specific to the area, so that there's specific resources, not just general resources, but also specific ones, and then also making sure that we're getting that bad and not proper information off of the internet, and really regulating what children are seeing. Because also, just not even related to mental health, but a lot of those negative things about body issues, Photoshop, all of those other things that are contributing to mental health issues, we need to address those in the conversation of social media as well. So I think it can be a very powerful tool, but I think that there's a lot of work that we need to put in before we start utilizing it to its fullest potential.
Nope. Okay. Thank you. Thank you very, very much. On that note, we kind of have to wrap up. It's late. I want to thank you all, each and every one of you. You have been incredibly articulate. It took a while, but then we started getting deeper and deeper and deeper into this. I'm very, very impressed with what you had to offer us, and the learning. Each one of you sharing in the way that you did was very, very helpful. Thank you very much for giving your time to us, so that we can make an intelligent decision, or at least a more informed decision, and leave this place more knowledgeable than we were when we came in. And everybody will do that tonight because of your work. So thank you all. So let's get into it. But I also want to thank all of you for coming and for sharing your thoughts and raising the issues and doing the studying and being members of the Catalyst. And I don't know what the rubrics are right at the moment, but for any of you that haven't made your contribution yet this year, there's still time. And in fact, there's still time to invite friends and other people. I actually had one thought tonight that I wanted to invite each one of you to become Catalyst members as well. So we can still do that there. Please do get that in. Our decision making, believe it or not, we have to make a decision. That's the next meeting. It's October 25th. We'll be making a decision. Now, Betty Ann and her team, we know how incredible they are. They will be putting out requests for proposals soon. I forget when this is but in July. They'll be putting out the RFP together in July. Applications will be due in September. We will make a decision in October. So that's all in process right now. And one person we ought to thank each and every time we meet is Betty Ann. And I think that's the last thing on my agenda that Betty Ann prepared for me.
Well, I'm just going to jump in there. If you're thanking me, then I'm going to thank all the other people that put this together tonight, Kristen and Kandiana, and all the team from here at the Thomas Hooker Brewery, as well as our communications team. Michaela back there, who did an awful lot of work. So it's not just me, Terry. There's a lot of us behind the scenes. But honestly, it depends on you guys. And we appreciate your being members of the Catalyst Endowment Fund and showing up. And we will see you in October. If you didn't get a cupcake, take one home with you.